Hey guys, so I'm going to talk about a TIPS procedure I did. So this patient's labs, they were low on pretty much everything because they were bleeding from their esophageal varices. They were chronic alcoholic, they had no known drug allergies, they had a CT before. They really didn't have any visual problems. They were a little on the pale side due to blood loss. They were intubated down with us because we did have anesthesia come in and help us with this case for sedation. They were an inpatient, so they were NPO. Medications were held that needed to be held. The TIPS procedure is more of we need to get this done quickly, so we do take precautions with any blood thinning medications to get them off as long as we can before we have to do the procedure. So this patient, they intubated on the bed. So we had a team of 4 people with the anesthesiologist who was watching the tube move the patient over very carefully. They weren't a very large patient, but still we were always very careful with the tube and the lines to make sure we still had good IV access and that ET tube didn't get pulled at all. Foot pedal was still the same. Patient didn't have precautions, but we were still wearing gloves to keep from bodily fluid exposure. Crush cart was in the room with us. Same sterile setup. The IO was covered, monitor was covered, table was covered, ultrasound was also covered. So we did use a lot of different tools for this, different wires and catheters. So we were going in the right jugular vein, the internal jugular. We were going to balloon and stent. So we were ballooning before we put the stent in. We did use contrast, and like I said, anesthesia was there with us. So we started by using ultrasound to get into the right internal jugular vein, which then after we numbed it up first, did a micropuncture needle, did the wire, then we did took the needle off, put the sheath on, and then we took that wire out and put a Benson down. And then what we did was we got our Benson down into the inferior vena cava. When we would normally use a 5 French, so we wouldn't have to dial up. In this case, we used a 10 French, so it was a lot bigger diameter. So we had to dial up from a 5 French, so there was less pulling and less it was easier for us to work that way. So we dialed up to a 10 French check flow angle tip sheath. That is a name. So then we took a 5 French catheter down over the wire to make sure we were getting down to the right spot. So we accessed the right hepatic vein and we did an angiogram to make sure we were in the right spot. At that point, we measured different pressures within the system. So we got 3 different measurements out of that. So after we measured, we took the Benson wire out and exchanged it for an Amplatz to make sure we would stay in the right hepatic vein. And we took out the catheter and we advanced our sheath down farther over the vein, or over the wire into the right hepatic vein. We took the needle, which I cannot say the name of, it's a very, very long needle which we use to puncture the liver. We advanced that down through the sheath over the wire, and the doctor had used it to poke into the right hepatic vein. So he did that twice. Usually, sometimes it could take a few more, but did that twice and accessed through it, which was good. We did exchange the Amplatz for a Roadrunner wire to make sure we were in the same spot, so we kept that through the needle. So we just left the needle there, carefully removed the wire, and put a new wire down. Then we took out the needle and put a 5 French glide cath over the wire into the proximal portal vein, and we injected contrast to make sure we were in the correct spot. We then exchanged that catheter for a pigtail catheter and placed that in the main portal vein, which at that point we removed the wire to run an angio or a digital subtraction venogram, not angiogram, to see the varices, where they were coming from. At that point, we then took an Anplatz wire down through the catheter and then removed it. We did dilations at the point where we saw the section that we needed to, where the varices were coming from. We dilated with an 8mm balloon, and we did put a 9 French sheath down and advanced it into the main portal vein over the wire. At that point, we took a 10cm stent and placed it right outside of our sheath and deployed it. At that point, we took that sheath out and put the pigtail back to do another digital subtraction and make sure we were in the right spot and make sure that the stent was correctly inserted. Make sure it was wide enough to block everything that we needed to. And that was that. So after we took it all out, we held venous pressure. At that point, we moved the patient. They were still intubated, moved them back to the bed. And this patient was going to our intensive care unit, so we left them vented and took them upstairs so they could recover and we could keep them sedated so they wouldn't pull at their neck or anything like that. So a patient was hooked up to the anesthesia stuff. The patient was supine. We did normal fluoro, we did a venogram and digital subtraction. We didn't use our power injector. We did use our power injector to do the digital subtraction runs. These are all the different veins we saw. And then we did use that 8mm balloon to kind of help expand that area for that 10cm stent. So what I've learned definitely from this is that there are a lot of tiny veins that are very confusing. So this is the right atrium, and I'm totally going to butcher this because this is a really bad picture, but this is the portal vein that we saw. So I believe that the right one is where we stuck the needle through. It all happened so fast. You're trying to ask questions, but you're trying to be efficient. I feel like with time, I'll understand it a little better. So like I said, we did take the patient upstairs. They were extubated upstairs on ICU. At that point, they were under sedation still because we didn't want them. They were bleeding, so they were getting tons of blood, and they were very uncooperative when they were awake because of the pain, and I think the patient was a little delusional, but they went upstairs, got recovered, and actually we saw the patients a few days later for paracentesis, which was actually pretty interesting to see how they were doing. And kind of one of the other doctors explained to me how the TIPS patients, their mentality after it happens, because typically this is like one of the life-saving procedures we do, and people do last long from it and sometimes they don't. But yeah, so that was my case study on the TIPS procedure I was involved in. All right, thanks guys.